Welcome to this Step 2 clinical knowledge review on pediatric fever test-taking strategies. This video is brought to you by Roadmap to Residency. We are going to break down the most common question patterns you will see on your board exam for pediatric fever, including fever without a source, age-based fever workups, Kawasaki disease, and febrile seizures. The goal here is not to reteach the entire topic, but to help you recognize the patterns and apply test-taking strategies. Make sure you have reviewed the pediatrics and infectious disease sections of first aid and your question bank before or alongside this video. Here is what we are going to cover today. First, we will learn how to recognize high-yield question stems for pediatric fever and fever without a source. Second, we will apply specific strategies for questions about age-based fever workups, Kawasaki disease, and febrile seizures. And third, we will master the next best step question format for evaluating and managing the febrile child across different age groups. This video assumes you have some baseline knowledge from your review resources. We are here to sharpen your test-taking approach. Our first strategy is the age-based fever workup split. When you see a question about a febrile child, immediately ask yourself, what is this child's age? The age determines everything. For neonates under 1 month with any fever of 38 degrees Celsius or higher, the answer is always a full sepsis workup with blood cultures, urine culture, lumbar puncture, and empiric antibiotics. There is no wiggle room here. For infants 1 to 3 months old, you need to assess how the baby looks. An ill-appearing infant in this age group still gets the full workup, but a well-appearing infant may be risk stratified with lab studies. The boards love testing whether you can distinguish which babies need the full workup versus those who can be observed with close follow-up. Strategy 2 is all about recognizing Kawasaki disease because the boards test this in several different ways. For classic Kawasaki disease, you need fever for 5 or more days plus 4 of 5 clinical criteria. Those criteria are bilateral non-exudative conjunctival injection, oral mucous membrane changes like strawberry tongue or cracked lips, extremity changes like erythema or edema of hands and feet, a polymorphous rash, and cervical lymphadenopathy. But here is the real board pearl: incomplete Kawasaki disease. When a child has prolonged unexplained fever with fewer than 4 classic criteria, the next step is to check inflammatory markers and get an echocardiogram. The feared complication is coronary artery aneurysm, which is why early treatment with intravenous immunoglobulin and aspirin is so critical. Now let us go through high-yield stem recognition. For fever without a source, the classic stem is a young infant with a rectal temperature of 38 degrees Celsius or higher and no localizing source on exam. The age of the child is the single most important detail in the question. For Kawasaki disease, look for a child with prolonged fever for 5 or more days accompanied by conjunctivitis, rash, swollen hands and feet, strawberry tongue, and cervical lymphadenopathy. The next step is an echocardiogram and treatment with intravenous immunoglobulin. For febrile seizures, the classic presentation is a child 6 months to 5 years old with a brief generalized seizure during a febrile illness. Simple febrile seizures are self-limited, and the answer is almost always reassurance. These stems repeat over and over on practice questions and on the real exam. Let us work through our first practice question. A 3-week-old full-term neonate is brought to the emergency department by his parents for a rectal temperature of 38.3 degrees Celsius. The infant is feeding well and appears non-toxic on exam. There are no localizing signs of infection. The parents ask if they can just observe at home. What is the most appropriate next step in management? Take a moment to think about this before we walk through the answer on the next slide. Let us break this down step by step. Step 1. Spot the pattern. 3-week-old neonate, fever of 38.3 degrees Celsius, no localizing source. The critical detail is the age. This child is under 1 month old, and that drives everything. Step 2. Apply the rule. The board rule you must memorize is: any febrile neonate under 1 month old requires a full sepsis workup regardless of how well they appear. This includes blood cultures, urine culture, lumbar puncture, and empiric antibiotics with hospital admission. The well appearance of the baby is a classic distractor. Step 3. Eliminate wrong answers. Discharge home is never appropriate for a febrile neonate under 1 month. Urinalysis only is an incomplete workup for this age group. Acetaminophen and reassess just treats the symptom and delays critical evaluation. The correct answer is C, full sepsis workup, empiric antibiotics, and hospital admission. Here is our second practice question. A 3-year-old boy is brought to the clinic with 7 days of high fever. On exam, he has bilateral conjunctival injection without exudates, cracked erythematous lips, a polymorphous truncal rash, and swelling of his hands and feet. His inflammatory markers are markedly elevated. What is the most appropriate next step in management? Think through this one carefully. Count the number of classic criteria you can identify. We will walk through the answer next. Let us work through this answer. First, count the criteria. This child has fever for 7 days plus 4 classic findings: bilateral conjunctival injection, oral mucous membrane changes with cracked lips, polymorphous rash, and extremity changes with hand and foot swelling. That meets the diagnostic criteria for Kawasaki disease. Now eliminate the wrong answers. Blood cultures and empiric antibiotics treat bacterial infections, not Kawasaki disease. Lumbar puncture is for meningitis workup, which does not fit this clinical picture. Oral corticosteroids are not the first-line treatment. Why does echocardiogram and intravenous immunoglobulin win? Because intravenous immunoglobulin plus aspirin is the standard treatment for Kawasaki disease and significantly reduces the risk of coronary artery aneurysms. An echocardiogram is essential to evaluate for cardiac complications. The correct answer is B, echocardiogram and intravenous immunoglobulin. Let us review febrile seizures for the boards, because this comes up constantly. Simple febrile seizures occur in children 6 months to 5 years old. They are generalized, last less than 15 minutes, and do not recur within 24 hours. The key board pearl is that the management is reassurance and treating the underlying fever. No anticonvulsant medications are needed. No imaging or electroencephalogram is required for a first simple febrile seizure. Now, complex febrile seizures are focal, last longer than 15 minutes, or recur within 24 hours. These require further investigation, including consideration of lumbar puncture, imaging, and electroencephalogram. The boards love asking you to distinguish simple from complex febrile seizures. If the question describes any atypical feature at all, you should think complex and pursue additional workup. Here is our third practice question. An 18-month-old girl is brought to the emergency department after a witnessed generalized tonic-clonic seizure lasting 3 minutes during a febrile illness. After the seizure, she is alert and back to her baseline with a normal neurologic exam. She is up to date on vaccinations. What is the most appropriate next step? This is a classic, simple versus complex febrile seizure question. Think about the age, the duration, the type of seizure, and the post-seizure exam. We will walk through it next. Let us break down this answer. First, confirm it is simple. This child is 18 months old, which is within the typical age range of 6 months to 5 years. The seizure was generalized, lasted only 3 minutes, and the child returned to her baseline with a completely normal neurologic exam. She is up to date on vaccinations. All of this confirms a simple febrile seizure. Now eliminate the overreactions. An electroencephalogram and brain imaging are not indicated for a first simple febrile seizure. Lumbar puncture is not required when the child is up to date on vaccinations and has returned to baseline. Prophylactic anti-epileptic medication is never recommended for simple febrile seizures because the risks of the medication outweigh the benefits. The correct answer is A, reassurance and antipyretics. Here is a critical test-taking pearl about the fever without a source approach. When you see a febrile child on the exam, your first mental step should always be to identify the age. Under 1 month, the answer is always a full sepsis workup and admission, no matter how well the baby looks. For 1 to 3 months, you risk stratify based on clinical appearance and lab results. For children over 3 months who appear well, you can often manage with a urinalysis, observation, and close follow-up. The most common source of occult bacterial infection in young children with fever without a source is urinary tract infection, so urinalysis is key. Also remember that vaccination status matters for febrile seizure questions as it determines the need for lumbar puncture. The exam tests these age cutoffs and management algorithms frequently, so commit them to memory. That wraps up our review of pediatric fever test-taking strategies for Step 2 clinical knowledge. Remember to review the pediatrics and infectious disease chapters in first aid and your question bank. Focus on the fever without a source algorithms, Kawasaki disease criteria, febrile seizure classification, and age-based management strategies we covered today. Visit www.roadmap2residency.com for expert tutors and residency advisors who can help you build a personalized study plan. If you found this video helpful, please like and subscribe so you do not miss our next board review session. Good luck on your exam, and we will see you in the next video.